Bismillah ar-Rahman ar-Rahim. Today, inshallah, we will discuss the first session in the cardio, which is hypertension. Hypertension or high blood pressure, according to the last classification, the blood pressure measurement, either non-elevated blood pressure, and that is definitely if it is 120. So, or normal. If it is above 120, up to 120 to 140, and 70 to 90 diastolic, that is elevated, but it is not a diagnosis of hypertension. And as you know, the hypertension definition is 140 over 90 and above. Type one question, which is very important. If we need to classify the blood pressure as non-elevated, both figures, systolic and diastolic, and diastolic, should be normal, should be below, يعني 119 69. Both should be there. If I want to say this patient is having a non-elevated blood pressure, it should be 119 69. That is absolutely normal. That means it is below 120 over 70, below. Not 120, not 70, below. And both, not 121 over 70, over 69. Both figures should be below this cutoff point. Both should be below these figures to say a non-elevated or normal. But if anyone, the systolic or diastolic, or anyone is between 120 and below 140, or diastolic 70 to 89, that's elevated. It is not yet hypertension, but it is elevated. And because why we are concentrating on this differentiation, on this classification, because on February, before 3 months or 4 months ago, there is a new recommendation in by NICE guideline or European guideline, and NICE also, to offer advice on healthy living to people who have a raised blood pressure but not yet diagnosed as hypertension. Those people, anyone who have high blood pressure between 120 below 140 or 72 below 90, even if the systolic is normal, or the systolic is in this figure, even if the diastolic is normal, these people will be like classified as elevated hypertension. And as per the new guideline, we should still offer them a healthy living to these peoples. This is very important even for whom, for OSCE exam. These people should have a healthy diet, low salt, and exercise, and blah, blah, blah. What the healthy living. What do we mean by healthy living? Healthy living. Yani, what are the figures of healthy living? What is the advice?
إنه الصوت يكون consumption أقل من 6 جرام. Exercise 3 times per week.
Exercise 3 times a week. So the diet. Let's talk about the diet. The diet, at least 5 portion of fruit and vegetables per day. At least 5 portion of fruit and vegetables daily. Whole grains rather than refined carbohydrate. Reduce the saturated fat, the fried food, the butter, the processed meals. Healthy fat, taking healthy fat like olive oil, fish oil. Limit the sugar and sugary drinks. Reduce the salt to less than 6 grams, as the doctor said. Fish twice per week. And adequate hydration as per the weather. That is for the diet. And this diet is very important for whom? For anyone with cardiovascular disease, whatever the disease, including hypertension, diabetes, and for obesity prevention. What else? Physical activity. At least 150 minutes per week. 150 minutes of moderate or severe intensity exercise. Like either jogging, walking, cycling, swimming. Okay, this is a 150 minutes of moderate to intense exercise. If he cannot do that because of any limitation, 75 minutes per week vigorous exercise. If you have no time, if you have no time for 150 minutes per week of moderate exercise, like jogging, bicycling, swimming, we will advise him 75, but vigorous exercise. Okay? Hi. Other than the diet and physical activity is a weight management. He need to keep a healthy weight between. How much is the body mass index which you recommend?
20.
The figure, give me the range.
20 to 25.
No. The range of healthy.
18 to 25 or 24?
18.5 to 24.9 or to below 25. Below 25. 18
Mama.
0.5 to below to 25. Yani we can say 24.9. That is a healthy body mass index. Okay? And if the patient is overweight, gradual weight loss, yani even if 10% of weight reduction is very good, can improve the blood pressure, improve diabetes, improve the risk of heart diseases. What else, Doctora? What else other than the healthy living, other than the diet, exercise, and weight control. What else? A very important healthy living advices.
Smoking and alcohol consumption.
Smoking, stop smoking. طبعا الاثنين الادفايس بتاعتهم مختلف. For smoking, stop smoking. Stop smoking will reduce the cardiovascular risk, the cancer risk, life expectancies. Right. We will say stop smoking. Number 4. Number 5, limit alcohol. Okay. Avoid the big drinking. Should have alcohol-free days each week. And who are the patients we should advise them to stop or avoid alcohol completely? Which condition we will say to the patient, you need to stop the alcohol completely now?
Pregnant woman.
Pregnant. Tani. Liver disease. Tani. Any previous misuse of alcohol. These 3 people should avoid alcohol completely. If you want to advise them, we will advise them to avoid alcohol. Okay, number 6 is sleep hygiene. Anyone should sleep 7 to 9 hours per night. And then the mental well-being. Mental well-being, you know, I work in for like 2 years in occupational medicine with ADNOC. The mental well-being is a very crucial, and there is target to be achieved, and they will do auditing for the staff, and there is a mandatory teaching should be done for the staff for mental well-being. And any defect, it will be very big negative points on the health system that is managing the company. There should be social interaction, stress management, hobbies, and recreations, like that. Okay, and then the preventative health care, like regular check of blood pressure, screen for diabetes when indicated, any schedule screening, influenza vaccinations, and then the other vaccination if indicated. These are the 8 elements of health living advices. See, all hidden in this small in 2 words. And it's a big topic. Okay? That is why some of your colleagues, they finish the station in the OSC and they happy, they came out happy that they manage. And actually they will get bad marks because they miss these advices, especially in a patient who is at risk for high blood pressure. And the SB will ask you, doctor, what do I need? What I can eat? What I can avoid? Exercise, doctor, I'm very busy. I cannot do 150 minutes. Then they squeeze you. You can do 75 minutes, but vigorous exercise. Doctor, can I eat salt? Can I drink alcohol? Can I? So he will hit you with a lot of questions. All these questions are marks. These are the markings that pass you. You got my why this times Sure. All right.
كلها تحت كويسة يا ماما. تغلصات في العضلات، هاي تغلصات في العضلات القلب. بعطيكي مسكن الحين.
Any question يا شباب؟
Sorry, Dr. Sammani. Regarding the alcohol consumption,
Yes.
I have a confusion regarding the units and how to calculate the alcohol unit consumption per week or per month. Or how is it?
Yes, I got your point. The calculation, it depends on the strengths in the type and the strengths. They will never ask you the calculation because no one can memorize it. Well, the whiskey, the vinegars, the champagnes, every types and every strengths of these alcohols have a calculation for the units per amount, per bottle or per cup. So they will never ask you. They will give you the units ready. Okay. Rarely they will ask you. He's drinking 1 bottle of whiskey every morning, for example. No, they will never do like that. The calculation, every types there is units, but they will give you how much is the healthy units per week? How much?
14, less than 14.
14, less than 14.
Yes.
Okay, less than 14 is the healthy drink. But how to calculate this? This depends on the types and the strengths of the types. Actually, in any manufacturers, there will be the calculation of the units. Same like if you buy any Coca-Cola, if you read it, there is how many calories in it. Same for any bottles of alcohols, there is how many units in it. I didn't saw it in reality. I saw it in the picture only. Okay. Any question? Right. This note, Jama, update it. It will be updated in the website just at the end of this lecture. Right. We agree, Jama, non-elevated blood pressure, elevated blood pressure, and hypertension. Hypertension, either systolic 140 and above or the diastolic 90 and above. And because there is confusion. So, for example, if I told you this patient blood pressure is 120 over 90, is this hypertension or not? Hmm?
Systolic hypertension.
Yes, hypertension.
Hypertension. It is hypertension, whether systolic or if we need to say systolic or diastolic, that is something else. But it may be hypertension if it is persist, if it is fulfill the criteria, but it may be hypertension. It is a level. If it is stable like that, if it is continue like that, if it is really 120 over 90, it is hypertension. Another example, 141 over 70. It is hypertension also. So any figure crossing the cutoff point, whether it is systolic or the diastolic, or of course both, it is hypertension. Okay. ما شرط الاثنين الفوق والتحت يكونوا عاليين. اي واحد فيهم كروس الريد لاين خلاص the patient will be labeled as hypertension if he fulfills the diagnostic criteria. What is the etiology of hypertension? High blood pressure or hypertension may be primary, which is 90%, and there is no any known cause, same like idiopathic, same like interstitial, like idiopathic lung fibrosis, same like type 2 diabetes, for example. So it's primary. There is no known cause. There is secondary, where there is underlying cause, whether it is renal or adrenal or whatever. And there is accelerated and malignant hypertension. It is hypertension, whether primary or secondary, but it is reaching a specific level with specific findings, a number, and a number associated with findings with the signs of retinal hemorrhage or papilledema on fundoscopy. White coat, which is the blood pressure that is, there is measurement discrepancy of more than 20/10 between the clinic measurement and home measurement. Type mask hypertension. If the clinic measurement is below 140/90, but ambulatory is more, and that's the opposite. In the clinic normal, in the ambulatory high, that is a mask hypertension. All right, let's go and discuss it one by one. The primary and the essential hypertension, the primary hypertension. When to say this patient is having hypertension? If we got a patient, we measure the blood pressure in the clinic, because this is where the patient will be detected at the beginning. So how the patient will come? A patient of 55 years old, he came to the clinic and he is on routine checkup, on job checkup, on visa checkup. The blood pressure is found to be above 140/90. That means it may be hypertension. علم عند الله لحد هسه. Okay, when to say this patient is having, what to do next? In the clinic, this is a measurement. What to do next? Same like asthma, we need to do eosinophils or FeNO or BDR or BEF or methacholine test to say this patient is having asthma. Or a patient with diabetes, take fasting blood sugar or random blood sugar or HbA1c on view of symptoms or not to say this patient is diabetes. Here, the blood pressure we need either home monitoring after the clinic. The clinic is high. We need to measure. We need to compare. How to compare? Either by home monitoring or ambulatory device. Which one is better? Both are same. Which is available, we can use it. Anyone aware about the difference between ambulatory and home monitoring? Anyone?
Ambulatory is continuous monitoring of blood pressure every 30 minutes. it kept for 48 to 32 hours.
No, I mean, if they gave you a patient, blood pressure is in the clinic, measured 140/90, checked twice in the clinic in this visit. And the blood pressure is above 140/90. And they gave you ambulatory and home monitoring. Which one you will choose?
Ambulatory.
Ambulatory.
I will choose ambulatory. It's over 24 hours. Even during sleep.
Why?
Even during sleep, it will give you the measurement.
It's more accurate.
Yes, more accurate. That's it. The device is more accurate than home monitoring. ليش? Device is not a personal dependent. It is not operator dependent. The home monitoring, the patient will measure. Wallahi, maybe he is talking while measuring. Maybe he is use tight cuff. Maybe he is not sitting comfortably because the blood pressure, if you want to check the blood pressure accurately, even as a doctor, you may not do it perfectly. We did like an audit and we used to examine the blood pressure check for the students in the last year. Many of them, they are not doing it correctly, although they have been teach and fresh. Patient should be sitting comfortably with the comfortable seat with arms and back is straight. The patient back supported, arm supported, sitting, and he was not smoking or walking for the last few minutes. And he should not talk and put the cuff in the middle of the arm, not tight fitting, not loose. And the measure, the blood pressure, patient should be relaxed in a quiet room. That is not possible for home monitoring. So if they gave you in a question, they squeeze you between ambulatory device and home monitoring, of course, the device is more accurate. It is more fast. It will give you the result tomorrow, and it is accurate. At least there is no misreadings and mismeasuring by the patient. Okay? And the patient sometimes may miss to measure. So the device is accurate, detect mask hypertension, detect nocturnal hypertension. It will measure by night while sleeping if there is nocturnal hypertension. Measuring during the sleep, which is very good. Home monitoring cannot do that. A lot of issue. Yes, the cost is a little higher. That is one is free, and this is one there is some cost in it, but that is not overall. The ambulatory device is superior. Okay, type. We already defined the blood pressure here, 140/90, but that is a clinic. Here we are talking about clinic. But if by ambulatory or home monitoring, the cutoff point is 135 and below, or 85 and below, or if the both figures are crossing this limit. So, for example, a patient came to us with a blood pressure of 140/90 in the clinic. We advised him to measure to confirm the diagnosis and to measure it by ambulatory device. And we took the average of the readings over the whole day. And it is 130 over 86 hypertension. 135 over 80 hypertension. Okay, Jama? Clear?
Clear.
All right. So in the clinic, if the blood pressure is below 140 over 90, here we will put him in the elevated, but it is not a hypertension. So we can say no need for further investigation. If between 120 and 70, so we can give him healthy living advice. But it is not, we will not tell him to go and do home monitoring. Yes, there is advice, but not home monitoring. Okay, Jama? If it is above 440, then we will be proceed. These are how to measure the blood pressure. Ambulatory, 24 hour. They can squeeze you. Ambulatory for 72 hours, for 48 hours, for 7 days, for 1 day. It is 24 hour. Monitoring every 15 to 30 minutes. We will tell the patient, I will put for you this monitor, this device. You can carry it on the belt, and there is cuff will be attached to the arm. It will squeeze your arm with every 15 minutes. Okay, from 8 a.m. to 8 p.m. at average of 14 readings. طيب, the question, we will take the whole readings day and night or the daytime reading?
Daytime.
Daytime. طيب, ما قلنا قبل انه الامبوليتري ديفايس بيساعدنا على النocturnal hypertension. Yes, it is just information, but we will not take the overnight measurement. Yes, it can help us to know whether this patient is having nocturnal hypertension or not. But we will take from 8 a.m. to 10 p.m. من الصبح ما يصحى من النوم يشرب شاهيه لحد ما قبل ما ينام تاني. Okay? It is not 24 hours. The device will be attached for 24 hours, but we will not take the whole readings. We will use only these readings for diagnosing. The other readings will be just information for us to know. Okay, Jama? طيب, يبقى we will take 14 readings at least. We can take the whole readings between 8 and 10. Fine. If the average is crossing 135 over 85, this is hypertension, is confirmed. We can now shift to the investigations, if indicated, management, if in the stage of management. Type. How about the home monitoring? Measure twice, morning and evening, each readings. Each reading should be twice. One minute apart when seated. يعني شنو? The patient will tell him to measure the blood pressure while we'll apply all these, the above, this one. We will apply all this one. Should be seated, should be calm, quiet, not smoking, not talking, not. We will check the blood pressure. He should check the blood pressure and record it and repeat it 1 minute apart. Okay, 2 readings at a time. Type 2 readings in the morning, 2 readings in the evening.
دكتور twice 1 minute apart in the same arm or a different arm?
No, same arm, not no need a different arm, same arm. Okay, this is for the morning reading and for the evening readings. Okay, 2 reading in the morning, 2 reading in the evening. And if he measured it for 7 days, the first day is like a training day or learning day. We will discard this reading. We will use the day or the second and onwards. If he measured for 7 days, then we will take from day 2nd to day 7. It's like 6 days. A minimum of 4 days is enough. Right. If the patient is diagnosed as hypertension, we said 135, 85 is diagnostic. But there is levels. How high is it? How above the 135 or 85? So the ambulatory or home monitoring, there is a stage 1, stage 2, and stage 3. In the clinic, above 140/90, but below 160/100, this is stage 1. Stage 2 is 160/100, above this 160/100 or above, but below 180/120. Like if our blood pressure is above 180 or above 120, that is severe hypertension. These stages are important to know because stage 1, there is approach. Stage 2, there is approach. Stage 3, there is approach. I'm talking about a patient for the first time who is newly diagnosed. After confirmation of the diagnosis, the next step is to classify. After the classification, and depending on that classification, we will decide to manage or not, or to follow. And if we manage, which one we will start? Which medication? طيب. After classification, what is the next step? وقلنا for every diagnosis, we need a full assessment before rushing to give the patient medication. To assess target organ damage. What do we mean by target organ damage? What is the meaning of target organ damage? Other than the urine, blood, ECG, fundoscopy. What is the meaning of target organ damage?
يعني الفيتال اورجانز البرين ليفر كده.
يعني why is it target?
The organs can be affected by hypertension itself.
The organ that is targeted by hypertension. The organ that is damaged by long-standing or severe hypertension, targeted by hypertension. Organ, a target for hypertension damage. What are the organs that can be damaged by hypertension? The kidney, the heart, and the eyes. That are the targeted, the organs that is targeted by, by hypertension. The heart, the brain, the kidney, and the eyes, blood vessels. Type for the heart, left ventricular hypertrophy, heart failure, coronary heart disease, myocardial infarction, atrial fibrillations. That's why we need to do ECG and maybe echo if needed, but at least ECG. Type for the kidney, we need the kidney function test, urea, electrolyte, GFR. For the eyes, retina, of course. We need to look for hypertensive retinopathy. Okay, so after the diagnosis, we need to evaluate. Because the patient is having hypertension. We confirm. We don't know how many years he has this hypertension. And whether there is any organ being affected. The organ that is targeted by hypertension is damaged or not. Okay? And we need to assess the cardiovascular risk by Q risk. That's a questionnaire. We will open in the application of the Q risk, or just in any Google, just Q risk. You will take a form, you will fill it, and then you will calculate the score. We should treat. The general rule is to be treated in the primary care unless severe hypertension. When we say severe, we are talking about a number only. When we say severe hypertension, we are talking about a number here. This is a severe hypertension. A number without any other damage. You will say this is severe hypertension. Why I'm saying this, Jama'ah? Then there is you'll be asked, what is this? Why you are referring this patient? You cannot say accelerated, sometimes malignant, sometimes severe, and they are using the term mistakenly. Severe means a number only. Accelerated means there is damage in the retina. Okay. So severe hypertension or referral, 180 over 120. What you will do? Refer. Accelerated. Type accelerated if there is papilledema and retinal hemorrhage or retinal hemorrhage. Or type suspected secondary, which is in any patient age below 40 is confirmed hypertension.
دكتور السيفير والاكسلريت دي ايرجنت صح؟ لكن السسبكت سكندري والايج 40 دي ما ايرجنت.
Come again, Doctora? The referral, yeah, we'll come to that one. When to refer and how to refer. See, it's now referral for severe and for accelerated hypertension, secondary or secondary. There is approach to management, and this is a separate topic. Not a separate topic, but at the end here in the lecture, there is what do we mean by accelerated hypertension and how we approach management. Okay. Any question? Are they the same, Jama, accelerated and malignant? Any difference between them؟ لحد ما نجي نشوفهم بعدين.
Yes, accelerate top emergency. Hypertensive
malignant.
emergency would be suspected hypertensive emergency.
طيب لا, I mean, what is the difference between accelerated and malignant? Which is more severe?
Accelerated.
No?
Malignant.
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 From the name.
Malignant. Malignant.
The name. This is malignant. Yani, see, if you are thinking about same like tumors, the tumor is something abnormal, something bad. Accelerated is like a tumor, malignant is like a cancer. Accelerated is any blood pressure above 180/20 plus retinal damage. Malignant is a more severe form of accelerated hypertension. Yes, the number is same. There is retinal damage and there is papilledema. Okay, malignant, there is papilledema. So let me make it clear for you. Okay, كده clear?
Yes.
Accelerated, malignant hypertension. Okay. Yalla, management. Okay, target. What is a target for the management? The target should be below 140/90 in any young patient. Young means less than 80. Okay, in the clinic. Or less than 140/90 or less than 135/80 if a patient check his blood pressure at home. We will tell him, your target, if we measure it in the clinic, 140, below 140/90. And if you check it at home, should be below 135/85. If anything, in a known patient with known hypertension, we already diagnosed, now we are treating. A known patient with known hypertension, the target in the clinic below 140/90, at home below 135/85. If he is below 80. Exception to that, if the patient is elderly patient above 80, then usually they have stiff blood arteries. So we will accept below 150/90. Type. In diabetes type 2, same. Unless the patient is having multiple comorbidities, frail patient. In diabetes type 1, the target should be in the clinic, like at home of the others. Because type 1, there is a severe risk for target organ damage. So we will reduce the target of the blood pressure. And we will reduce it more if the patient with type 1 and albuminuria or type 1 plus metabolic syndromes features. So the target should be below 130/80. Okay, how many targets we have here? We have a target for all people who are young, even those with type 2 diabetes. The target is below 140/90. Type 1, the target in the clinic below 135/85. Target for type 1 with albuminuria or metabolic syndrome below 130/80. We should memorize these numbers. Remember, no exam without 2-3 question minimum in hypertension. No exam in the OSCE without hypertension. And sometimes 2 cases, hypertension or hypertension-related conditions. When to start treatment? Class, we diagnose, we set a target according to the patient information. A patient without specific feature, or a patient with type 1, or a patient with type 1 and having comorbidities, renal comorbidities, we set the target. Type. How to manage? With medication or with just healthy living advice? Healthy living advice for any patient with elevated blood pressure but not reaching hypertension. What about those who is hypertension, diagnosed hypertension, labeled as hypertension? According to the stage. Yes, that is why at the beginning of the lecture we said when we confirm the blood pressure, Next step is to staging. Same like a patient with a cancer. When we diagnose a cancer with the biopsy, next step is to do CT, abdomen, pelvis, and chest. To staging. Your blood pressure also will stage. Stage 1, stage 2, and stage 3, the severe one. So if it is stage 1 and the patient is young, below 80, then we will start treatment immediately. If this patient have any, he is young, below 80, and have any of target organ damage. And that is why after the diagnosis, we will do, after the staging, next step to the staging, target organ damage. ECG, renal function test, lipid profile, HbA1c, and the creatinine, albumin. Okay, and fundoscopy. Target organ damage. Any patient with hypertension, whatever the level, and have target organ damage, treat. Start immediately treatment. Establish cardiovascular, treat. Have a risk for cardiovascular in the coming 10 years. The risk is more than 10%. Treat. Renal disease, treat. Diabetes, treat. Look at the scenario. You will find any one of this information. He will give you, this is blood pressure high, confirm, information, his lab test is one, lab. What you will do, treat or observe, treat if any. Type. Stage 2 is easy. Class, stage 2, start treat immediately. Treat. Stage 3, we already agreed urgent referral or treatment immediately. Right. If the patient is having blood pressure of 180 over 120, either admission or referral. Admission if there is papilledema or unstable. And when we say unstable means confusion, chest pain, heart failure, kidney failure. Refer if there is target organ damage, right. We start the treatment if treatment is indicated. Then step 1, step 2, step 3, step 4. For young patient and white, we'll start with AC inhibitors, ARBs. For above 55 or black, whatever their age, even if they are young, calcium channel blockers. Right. Whether we start with ACE inhibitor or calcium channel blockers, if the patient is not controlled, we will give the other. Yani, if we start ACE inhibitors for a white patient and young, ACE inhibitors. And if we had to add something else, we can add calcium channel blockers in the next step. And the opposite is still true. Bye. Step 3, thiazide-like diuretics. Add on طبعا. And here, not like in angina, يا جماعة. In angina, we will increase the first dose first. When we reach the maximum, then we can add another one. But in hypertension, they encourage to add another one early. No need to maximize the dose of the first drug before adding. No need. If not controlled, we can add a second drug. Better than to increase the dose of one. Why, يا جماعة?
What is the
ليش
question, doctor? معلش.
why يعني the best is to add another one rather than to increase and maximize the dose of one drug. And for example, if a patient started amlodipine 5, whether you will increase to amlodipine 10 or add losartan?
عشان السايد افكت يا دكتور.
reduce side effects.
No?
السايد افكت بتاع ال other drugs.
No.
The way of control of blood pressure, الميكانيزم of action of medication بيشتغل على أكتر من حتة فبيتا تؤات يعني واحد أدينوزين أنجيوتنسين مثلا سنتر واحد بيشتغل.
Same idea. Because the blood pressure is multifactorial. Okay? It's not like angina. Angina is straightforward. But the blood pressure is multifactorial. There is obesity, there is lipids, there is aging, and there is renal, and there is so multifactorials. And the control of the blood pressure depend on managing this risk altogether. So adding a medication better than to increase the dose of the first medication. Okay. Step 4 depends on the potassium. Potassium less than 4.5, we can give spironolactone. If above, we will give alpha blocker or beta blocker. Of course, if the patient is having ischemic heart disease, we choose مثلا beta blocker. If he have, depends on the other information given in the scenario. Will help us to select which drug. Is there any contraindication? So we can jump, if there is any contraindication to say thiazide-like, of course, we will jump to the fourth step. Any questions so far?
يا boss.
Yes?
Previously, it was step 2, adding C or D, I remember. Then step 3, add C or D. Now it's the same or changed?
For step 2, add
Yes.
A to C. Huh?
Yes. Or D. Sometimes they told or D from the step 2. Yeah.
Okay. See, yani it is not technically for exam-wise. They will give you the information which will help you to select one over the others. For example, they will give you this patient is having gouty arthritis. So they are pushing you away from what?
D.
Yeah.
Like diuretics. Yeah.
So, for example, like that. They will give you this patient is having a prostate, for example. So they are pushing you if this patient is
blockers.
heart failure, مثلا, for example, they are pushing you away from beta blocker. So it's like that.
Okay.
If there is no any other limitation, then we will follow these steps. But usually they will give you clinical judgment, because choosing a medication is a clinical judgment based on your concentration on the information, which will Yani the information that is either indication or contraindication. Asthma, for example, you cannot give beta blocker. They are pushing you away from beta blocker if they mention asthma in the patient scenario. Am I right? So like that. If the patient is having frequent stones, if the patient is having, for example, he having renal artery disease or like that, or if you have peripheral disease, so we can choose calcium channel blockers, like, or he is intolerant to one medication.
Okay.
Type. Usually, if they give you ARBs is better than ACE inhibitors if there is cough. Okay. Indapamide better than bendroflumetazide if they gave you both, and both are thiazide like. Okay. How to monitor if we start the medication? Monthly. So Indowski, I will give you, I need to see you after 1 month. If the patient newly hypertension, or we newly started medication on him, so how long I will see him after 1 month? Okay, if controlled and happy, then we will see him after every 1 year or every 6 months maximum. Okay, urea and EGFR before and during treatment. Well, I remember there is one patient a few weeks ago, like few days, few weeks. He came and he's having a confirmed high blood pressure, but he don't have lab measurement. And he came by taxi and he want to go fast. He don't want to do investigation to guide the treatment. And his blood pressure is really high and there is no nearest appointment. It's real practice. They will squeeze you with a question like that. Okay. What to give if you are in my place? Patient came to you with a blood pressure 170 over 100 and known diagnosed as hypertension, but he's not started treatment. He came today and he want to be given the medication. He convinced to take the medication. He don't want to do blood test. So you cannot give him medication without the electrolyte EGFR. What is the safest medication that can be given without checking urea electrolyte and EGFR?
Calcium channel blockers.
Calcium channel blockers. All right.
هو diagnosed يا بص ولا شنو؟
Yes, yes.
ما سمعت
Diagnosis. ما هو لو ما diagnose هنضطر نعمل diagnose جديد، لكن هو diagnosed already. Labeled hypertension, but he didn't start any medication. Okay. Like for example, they told him, okay, you have high blood pressure and we need to do some check. And okay, come next time. Or they call him, he didn't came, and he just came on medication because now today the blood pressure is shooting very high. His blood pressure on diagnosis was, like, for example, like 150 over 6 over 90, and today he is shooting blood pressure. And khalas, he said, no. Okay, this health style and this is not enough. I want medication today. Okay, let's do blood test. He said, no, I have no time. Okay, so we cannot leave him go without blood pressure medication, and we cannot give him ACE inhibitors without checking urea electrolytes and EGFR and having follow-up set after 1 month. Any question? I know you have a lot of questions, but it is all there for the blood management of blood pressure. In diabetes, management of blood pressure. In pregnancy, management of blood pressure. When there is retinal diseases, when there is heart disease, when there is diabetes. Okay. That's 5 minutes, and then we'll come to talk about secondary hypertension. 5-minute break.
Okay.
We already discussed the hypertension diagnosis, how to diagnose, what are the steps after the diagnosis, staging, investigation for target organ damage, and the steps of management. Now, for special situations, first, secondary hypertension. In any scenario where the patient is below 40, have hypertension, we need to roll out secondary hypertension first. So there will be a mandatory steps in the approach for the patient with high blood pressure, diagnosed, confirmed as hypertension, but his age is below 40. Then, and he's having stage 2 hypertension. So we can say this is the main categories of patients which we will suspect a secondary hypertension. Below 40, second stage. There's other scenarios where we will think of secondary hypertension. If the blood pressure is resistant to treat, difficult to treat, if there is difficult patient uncontrolled with 3 medications, here we will think of secondary. That means there is something else, there is something in this patient preventing the control. Okay? So, same like if a patient with epilepsy, he came with his known case of epilepsy, he came with attack despite medication. Maybe disease inside him. A patient with diabetes, not controlled with medication, maybe disease inside him. So this is a D. D. The D of daily exercise, diet, drug, disease, drug interaction. Okay? Type. A patient with difficult to treat blood pressure, we need to think of secondary hypertension. If 3 medication is not controlling. Type below 40 with stage 2. Resistant despite 3 medications not controlled. Sudden severe onset of blood pressure, usually the blood pressure is a gradual. But sudden severe from normal to very high, you think of secondary. Any patient with malignant hypertension, we think of secondary. Paroxysmal or associated with symptoms of paroxysms. Patient is having renal deterioration and high blood pressure. We will think of the blood pressure as a kidney-induced blood pressure. If there is any clinical clue, patient with a moon face, buffalo hump, a patient with acromegaly features, a patient with any feature of endocrine disease, lab result, sodium, potassium. So here we can think of secondary. These are the scenarios where we need to think of secondary hypertension. What are the causes we need to put as a differential diagnosis? Primary hyperaldosteronism. The aldosterone production from the adrenal gland is high. The adrenal become crazy, produce high aldosterone. طيب, in this patient, what about the renin يا جماعة? What is the status of renin in this patient? Will be low or high? شباب, primary hyperaldosteronism, Cone syndrome. Renin is high or low?
High.
Low, suppressed.
Low. Why low? If the what is the يعني what is the hikmah of behind the creation of renin? Okay, renin is if the pressure in the glomeruli is low, that renin will be secreted to increase the blood pressure. طيب, to increase the aldosterone will increase the blood pressure. طيب, if the aldosterone from the adrenal is high, he don't need the renin. He is high and he is causing high blood pressure. That means this is the opposite situation. Renin will be elevated if the blood pressure in the juxtaglomerular apparatus is low. If the blood pressure is low here, renin will be high to increase the blood pressure. But if the blood pressure is from something else is high, there is no need for the renin will go down. ما محتاج إلا خلاص. الالدوستيرون أصلا من الأدرينال طالع هاي. يبقى ما محتاجين إلا stimulation. محتاجين العكس. Renin will be low, not normal. If it is normal, that is abnormal. Same like parathyroid. If the calcium is normal and the parathyroid, if the calcium is high and the parathyroid is normal, that is abnormal. ما مفترض ينزل. فالرنين in a patient with primary hyperaldosteronism, the renin should be low. There is no need for it. اصلا هو الرنين ربنا خلقه عشان يرفع الالدوستيرون. طيب, الالدوستيرون جاي من امه هاي, فالرنين will be down. Clear يا جماعه؟ لانه sometimes it will be the only differentiation. Okay. If the blood pressure is down due to renal artery
يعني
stenosis.
النيجاتيف فيدباك يعني.
Yes.
Okay.
Yes. Okay. So if this is a kidney and the renal artery is stenosed here. So the blood pressure in the glomeruli will be low, the renin will be high. And the aldosterone will be high نتيجة للهاي renin. الهاي renin high نتيجة renal artery stenosis. This is a secondary hyperaldosteronism. Secondary to what? Secondary to high renin. High renin secondary to what? To low blood pressure. Low blood pressure secondary to what? To renal artery stenosis. Or even if hypotension, severe hypotension, renin will be elevated to compensate. Same like bicarbonate compensation for respiratory acidosis, and the opposite. That's a compensation. Okay. In a patient with high blood pressure, if we think about primary hyperaldosteronism, high sodium, نتيجة high aldosterone will reserve the sodium and secrete the potassium. Right? That is why in the primary hyperaldosteronism, class high sodium, which elevate the blood pressure, low potassium, and then metabolic alkalosis. And low potassium, there will be loss of hydrogen ion instead of potassium. Loss of hydrogen ion, there will be metabolic alkalosis. So any hypokalemia associated with alkalosis. عشان كده يقولوا metabolic hypokalemic alkalosis. And the opposite is 3. It's true. Right. Renal artery stenosis. There will be feature. Cushing syndrome. Same like high aldosterone in the cons, high cortisol in Cushing. Both musiba is from the adrenal gland. Okay. In hyperaldosteronism, there is electrolyte imbalance because it is mineralocorticoid. In Cushing, there is high cortisol, increase obesity and striae glucose intolerance. In pheochromocytoma, again, the same musiba is from the adrenal, like from adrenal medulla. This is a catecholamine linked to nerve stimulation by nerve, by sympathetic and parasympathetic, stimulated by high sympathetic, inhibited by parasympathetic. That is why sometimes high, sometimes low. Bullous, paroxysms. Why paroxysms? Why is a pheochromocytoma? There is paroxysms of symptoms. لأنه the control of the pheochromocyte, the chromaffin cells, is by the autonomic nervous system. An autonomic nervous system is not fixed. Depends on the physical and mental and emotional and the functional status of the body at that moment. In the moment where there is sympathetic stimulation, there will be hypertension, palpitation, diaphoresis. And in the time where the patient is sleeping, relaxed, there is parasympathetic, the blood pressure will be normal. If we find a patient scenario with these symptoms, paroxysms of catecholaminergic symptoms, this patient mostly have hypertension due to pheochromocytoma. All right, other endocrine also associated with essential secondary hypertension. Not too much, but it is there. Hyperthyroidism, growth hormone, obstructive sleep apnea, and we learned that in obstructive sleep apnea there will be vasoconstriction نتيجة للhypoxia. So there will be hypertension. And because there is another element like obesity and whatever. Type. How to investigate? Investigate directly and targetedly the underlying cause, possible underlying cause. In primary hyperaldosteronism, we will check the renin and the aldosterone ratio. In the pheochromocytoma, because the secretion is not stable, Now maybe the catecholamines high. After 1 hour, maybe low if the patient went into relax. So we cannot check the adrenalines. So better to check, the metanephrines, the metabolite, which will be stable over 24 hours because it is secreted by the kidney. Excreted so. So it will be there stable for 24 hours, regardless of the bolus secretion of the adrenaline. Adrenaline, if secreted at this moment, now 11 o'clock or 12 o'clock, 5 grams of adrenaline secreted. After 1 hour, 1 gram. After 3 hours, 10 grams. All will be collected in the urine over 24 hours. So it will give us same like we are checking ambulatory device for the blood pressure. Here we will check the 24-hour metabolites of the catecholamines. So pheochromocytoma, check 24-hour urinary catecholamines, not adrenaline. Okay, for Cushing, we learn already to do overnight dexamethasone suppression test and so on. If a patient suspected renal artery stenosis, then CT angio. All right. Management of the secondary hypertension, first manage underlying cause. And we know underlying cause is hyper for any endocrine. The treatment is mostly surgery. As a general rule, all the hypers in the endocrine are surgery. There's only few exceptions, like for prolactin, we can try. Acromegaly, still we can try some medical. But all the hyper treatment is surgery. And control the blood pressure. So if a scenario patient result hypertension and hypokalemia, we'll think of course. طيب يا جماعة, if a patient came with hypotension and there is hyperkalemia, what do you think?
Addison's.
Addison. Okay. Hypotension and hypokalemia or hyponatremia or both, then we will think of Addison. Hypotension, hyperkalemia, and hyponatremia. Right. Let's come to hypertensive emergencies. Or we have the severe hypertension. We said when to say this patient is having severe hypertension if have the blood pressure is above 180 or above 120 diastolic. 180 itself or 120 itself. One, of course, without target organ damage. This is severe hypertension. If there is target organ damage, either this is accelerated or malignant. If there is papilledema, malignant. If there is retinal without papilledema, this is accelerated. Fine. Other than accelerated and malignant, is there any other emergency? Yes. If there is aortic dissection, it's emergency. If there is patient is having hypertension and coronary artery, even if the number is low, And even if it is stage 2, for example, and the patient have coronary arteries, this is hypertensive emergency. Aortic dissection, hypertensive encephalopathy, stroke, kidney injury, eclampsia. Eclampsia may be patient, but just patient is 140/90, but it is still hypertensive emergency. So the absolute blood pressure level is less important than the presence of acute organ damage. You got this point, Ijma, or I need to repeat it? Again, severe hypertension, when the blood pressure is reaching this point without organ damage. Accelerated is above 180/20 plus retinal. Malignant, above 180/120 papilledema. Okay? Now, the other issue is hypertensive emergency. It's not necessarily to be 180/20. 180/20 for severe, for accelerated, for malignant. But for hypertensive emergency, if there is acute coronary syndrome or acute heart failure, pulmonary edema, aortic dissection, hypertensive encephalopathy, stroke, kidney injury, eclampsia, any blood pressure with any one of these, any blood pressure as after the cutoff of the hypertension, أي عيان عنده hypertension, whatever the hypertension stage, and he's having any one of these, this is a hypertensive emergency. How to approach? You are in the clinic and the patient came to you and the nurse told you that the blood pressure is 180/120. Bring me the patient. She brought the patient into you. What is your next step? The patient is sitting in front of you and he's asking, what you will do for me? Doctor, please reduce this blood pressure. And the family will push you. Doctor, his blood pressure is very high. We are coming running. We should, radars is hit us. And so before any decision to start medication, we need to assess. We need to assess because زي ما قلت لكم blood pressure 180/20, there is three differentials أو three classification, either severe or accelerated or malignant. We need to know. صح ولا لا يا جماعة؟ blood pressure 180/120, I need to classify this blood pressure either severe without damage, accelerated with retinal damage, malignant with papilledema, or if he have any one of the element of the emergency. Is he having a coronary artery, heart failure, aortic dissection, encephalopathy, stroke, kidney, eclampsia? According to the assessment, then we will decide. If accelerated or malignant, same day specialist assessment or admission. Same day referral. If accelerated or malignant. ده سؤالك يا دكتور الكبير علقت عليه. طيب. If there is life-threatening symptoms, this is emergency. If any one of these, emergency hospital admission, same day admission. Okay, life-threatening, emergency, hypertension, admission. It's the hospital.
So, during the
Yes.
referral ما بنديهم treatment، ما بنديهم أي حاجة ولا كاتوبريل sublingual ولا شيء.
We will come to that point. Now, the main approach. لأنه why I am concentrating on this at the beginning. Doctora, I will ask you one question. If you are in an exam, they gave you patients having blood pressure 180/120. They gave you the option same day specialist assessment or give labetalol. Which one you will choose?
Same day admission طبعا.
Yes, superior to the medication. As exam
Yes.
question. As exam question. This is the main approach. The referral. لأنه if you said I will give treatment, that means you don't want to refer. Why we will refer patient with 180/120? Why?
To prevent the organ damage.
And we said this patient blood pressure like this is most maybe secondary. This need intensive investigation to know if there is any secondary elements or no, and to treat the blood pressure and to treat the complications or to prevent more complications. So the main treatment is same day referral. If life threatening, by ambulance admission. طيب if suspected في chromocytoma, urgent specialist referral because it's not that serious. This comes and goes. We can make within 2 week referral. طيب if there is no emergency feature, it's only severe, no acceleration, not malignant, no emergency. We need to investigate before giving any medication. Okay? We can say the general rule is not to treat. It's just a number. So, investigate urgently. Finally, we will treat, but the next step is investigation. طيب عملنا الانفستيجيشن. He is just having a high blood pressure above 180/120. No acceleration. No retinal hemorrhage or cotton wool. No malignant. No bubble edema. No emergency. So investigate. Relax and investigate. إذا ظهر any target organ damage, then start treatment immediately. No need for home monitoring. No need for ambulatory device. A patient ليه ما محتاجين home monitoring or ambulatory device if the patient is having organ damage? Can someone give me the logic behind this decision, behind this approach?
Because mobility is chronic for a long time.
Yes, already the organ damage confirming the blood pressure is really high, that reach the level that it is stay there for a long time with this patient, maybe 1 year. It reaches the level that cause damage to the organs. It is not a blood pressure. It's not a white coat hypertension. It is not a temporal hypertension. This is significant hypertension. Stay for a significant time. No need for ambulatory or home monitoring. If there is target organ damage. If there is no target organ damage, maybe this is just temporal elevation. Nothing, no guarantee. It is. It need an immediate treatment now. If there is no target organ damage, maybe he's just having the blood pressure now. Maybe he's having he recreational drug. He white coat hypertension. He's in a stress situation. Whatever, maybe anything. Even if the blood pressure is above 180 over 120, no acceleration, no malignant, no emergency. We check the organ targeted by the hypertension. There is no targeted organ damage. Kidney is okay, eye is okay, heart is okay, ECG normal, echo normal, no brain issue. Kalas, this blood pressure mostly not serious and maybe new and maybe temporal. Go and confirm it first. Tell the patient, reassure him it is just a number and it is very acute and new. There is no organ damage. There is no serious, there is no emergency to treat now. Give you chance, let's test, let's be sure that it is really high. How to be sure? Yes, maybe ambulatory, maybe home monitoring, but there is a chance here. Even if we measure it in the clinic once, that is enough. دي الحاجة الوحيدة اللي the only exception from 7-day home monitoring, the exception from 24-hour device, we can check in the clinic once. If it is still high, then we can say this is a hypertension stage 3, severe hypertension. We can start medication immediately after confirmation, not immediately. وقع عليكم يا جماعة. And believe me, there is I usually give stories from the practice, matching the guidelines just to memorize the things. an interview, a very good doctors, we recommend him for interview for a cardiology unit. And then he came to interview and the cardiologist in front of me, he asked him, a patient came to you with a blood pressure 180, 200 over 120. And he have no any other issue other than mild headache. And he is first time visit. What you will give him? And unfortunately, the doctor told I will give labetalol tablet. Although it is therapeutic level, but they fail him the interview, the whole interview. Although it is 200 over 1, and everyone, even the cardiologist himself, he will not let the patient to go like this. But in the exam wise, they don't want you to treat. So what is the next step is to roll out accelerated, roll out malignant, roll out emergencies, check in organ damage. If nothing, ask the patient to come another visit to check the blood pressures. Give him paracetamol only. And this is frequently asked questions. Clear, Jama, at this point?
Yes, yeah.
Or to repeat it?
دكتور ال 180 ال 200 البيشنت ده مش confirm hypertension وستارت تريتمنت على
No,
طول؟
first visit.
ما هو one reading 160 على 110 صح؟
كيف؟
confirmed انه ما هو يا two reading separate occasion او one reading 160 على اكتر من
No.
110 صح؟
منو قال كده؟ Who said that?
180 ما diagnose للهايبرتنشن؟
No.
او 200 ما عنده
No. We need to repeat. Here, this one here. This patient, blood pressure 180 over 120, sir. If there is no acceleration, no malignancy, no life-threatening, no pheochromocytoma, no end organ damage, urine analysis, SCR, urea electrolytes, ECG, fundoscopy, all normal, we can say this is hypertension? No. We need to repeat once, at least once within 7 days. At least once within 7 days. Or ambulatory. What to give him now? Nothing. We will treat immediately, start antihypertensive immediately if target organ damage. Here we can start that. We do not wait for the ambulatory or home monitoring or another visit because there is target organ damage. يا جماعة target organ damage ده براو confirmation. صح ولا لا دكتورة؟ ده الكلام اللي قلنا قبل شوية. قلنا target organ damage is a confirmation. This is same like a repeated measurement. يعني if you find there is a smoke, there is a fire in there. So if there is end organ damage, the blood pressure is significant and it stay for a long time. It is confirming that this is a long-standing hypertension. But if there is no end organ damage, we don't know. Maybe it is just elevated today. Tomorrow may disappear. We don't know. We cannot treat like that. We need at least to measure it once in the clinic or ambulatory device 24 hours or home monitoring for 6 days. Okay? This question came many times. Usually people, because they are applying to the practice, we will not apply the practice in the exam. You got the point, Jama?
Yes,
Anyone
yeah,
have a
boss.
different? All right. طيب, if you are in the hospital and they send to you, we said here we will refer, same urgent referral, same day admission, same day specialist. So if you are the specialist or the patient asks you, doctor, you are sending me to the specialist, what he will do for me? Or they ask you in the AKT, patient came to you, sent from the clinic, and you are in the hospital practice. What you will do? A patient with accelerated or malignant or emergency or end organ damage. What you will do, what is your approach? The approach is to reduce the blood pressure gradually, not rapidly. Okay? Why? Because if there is accelerated or malignant or end organ damage, already the patient is now setting himself, the body is setting its organs to the high blood pressure. So if you reduce it suddenly, there will be hypoperfusion. That is why a patient with a very high blood pressure, we cannot reduce it suddenly. will develop brain hyperperfusion if you give him labetalol IV or high dose. A patient will develop brain hyperperfusion. Even if he is not in a confusion or coma, he will go into coma because of blood pressure reduction. Okay. That is why we should not reduce it rapidly. Okay. Brain, heart, and kidney will be affected by rapid reduction of blood pressure in a patient with hypertension for the first time.
Perfusion, low perfusion. Affecting because it affects the perfusion of the tissue. If you reduce rapidly.
Yes. Okay. Fine. Okay. We agree not to reduce it rapidly. How we reduce it? How we can reduce it?
Gradually.
How gradually? Reduce the blood pressure?
From 25% from
25% in the first hour.
Yes.
Okay. Reduce the mean 20-25% during the first hour. If the blood pressure is 100 or 200, we can reduce it 40 only to 160 within 1 hour and then stop. Then gradually over the next 24 hours. So we can reduce up to 20%, 25% in the first hour, like after that, very gradually. Not to normalize the blood pressure immediately. The family will be happy, the patient will die. Okay? So we are not treating the number. We are treating this patient who have his brain, heart, and kidney set it to the high blood pressure. We need to treat the whole ideas, not a number. I know the family will push you. Doctor, the blood pressure is not reduced. It is still high because they are thinking like it is a temperature of a car. They want to reduce it fast. Okay? A patient with a blood pressure, for example, 250 over 140 and papilledema, of course, should not have the blood pressure lowered to 120 over 80 immediately. You will lose the heart and the eyes and the brain. It will develop ischemia, same like MI, acute MI, acute stroke, acute kidney injury. All will happen because this organ will develop hyperperfusion. Same like if the patient is hypotensive, blood pressure is 60 over 40. Especially the kidney. لأنه أصلا هي the first organ which will suffer from the hypoperfusion. Okay. What drug we can use to reduce gradually or commonly used in emergency? The labetalol, nicardipine, sodium nitroprusside, that's for emergency situation. Okay. Special conditions, if hypertension encephalopathy, gradual reduction, not to increase the encephalopathy. Pulmonary edema by vasodilation and diuretics, acute coronary syndrome, control reduction, ischemic stroke, Keep it unless it is very high. Leave it. In ischemic stroke, don't reduce it. Okay. Aortic dissection, yes, we are obligated to reduce it rapidly. Because the consequence of high, even normal blood pressure, we don't want. We need to reduce it despite any complications that can happen. Because aortic dissection is serious. So the benefit outweighs the risk. That is the only exception that we can reduce the blood pressure fast. Aortic dissection. That is the important exception. And usually the aim is systolic below 120, rapidly. That is why in this patient we can give labetalol, a moderate or high dose, to prevent aortic rupture. Right, this is a scenarios. A patient with blood pressure, high papilledema, same day. Chest pain, same day. Acute kidney injury, same day. Retinal hemorrhage, same days. Type. Dictora. Asymptomatic, no end organ, repeat 7 days. Or ambulatory. A patient with high blood pressure, but there is an organ damage, start immediately. Because there is an organ damage. This is confirmed. Like a blood pressure, which is confirmed. There is nothing for the same day, no referral, but there is indication to treat, no confirm. Confirmed organ damage. Okay. Examples? All right. This is another way of description of hypertensive retinopathy and accelerated and malignant. Okay, now hypertensive retinopathy. Hypertensive retinopathy different from diabetic retinopathy because the mechanism. In diabetes, the retinopathy is due to what, ya jama?
Long-standing chronic micro.
اللي هو will lead to what? Ischemia.
بيحصل ischemia يعني زي الاوكلوجن.
So there is ischemia. Ischemia, there will be a soft exudate, a hard exudate. Ischemia. Same like scarring in heart MI, old MI. So in diabetes will lead to atherosclerosis. Atherosclerosis will lead to ischemia. Ischemia will lead to, at the beginning, soft exudate, then hard exudate, then hemorrhage because of new vascularization. Ischemia will lead to new vessel formation. This is a proliferative retinopathy. That is a diabetes type. What is the difference? The blood pressure retinopathy, the hypertensive retinopathy is due to high pressure, high pressure in the retinal artery branches, not ischemia. So no cotton wool. If there is, but it is later. At the beginning, there will be high pressure in the retinal artery branches. You can see it either in the form of silver wearing. That means the retinal arteries, the wall of the retinal artery became stiff like it is have been coated. That is a silver wearing. There is coat on the periphery of the artery because of high pressure. That is a silver wearing. And there is arteriovenous narrowing. High pressure in the retinal arteries compress the retinal vein at the crossing site. Okay, that is a nibbing. Then there is a hemorrhage because of high pressure. Hemorrhage will lead to, if there is hemorrhage from artery, there will be, other than the hemorrhage, there will be ischemia. Will lead to cotton wool and hard exudate and macular star and then the papilledema. So, this is Ashno. What is this, Ajama? This is arteriovenous nipping. Here, in this circle. This is arteriovenous nipping. Here, it's maximized here. Okay, silver wearing. An arterial narrowing, arteriovenous nipping. This is stage 1 to 2. Stage 3, there will be blood or exudate. Stage 4, papilledema. This is a silver wearing, Ajama. Here you can see, same like there is a wires on the two walls. Same like الغلاف بتاع غلاف فضي أو لون فضي داخل الارتريز. Then cotton wool spot and flame hemorrhage macular star. Any papilledema in patient with hypertension is malignant hypertension and proven otherwise. Like usually it will be in a very high blood pressure. Differentiation or what to do for papilledema, same day. How to differentiate between diabetic retinopathy and hypertensive retinopathy? Arteriovenous nipping, silver wearing, flame hemorrhage. Okay. Flame hemorrhage and cotton wool will be for both hypertension and diabetic. It's there. Okay. A patient 58, blood pressure 200 over 130, fundoscopy, arteriovenous nipping, silver wearing. What is this? This is grade 2 hypertensive retinopathy. Flame hemorrhage, grade 3. Papilledema, grade 4. Clear, ya jama? If there is new vascularization, this is diabetic. Any questions so far? Right. Hypertension in diabetes. Target. قلنا type 2 معناه شنو؟ Same like normal people. Okay. Unless frail. Unless he have kidney disease. Type 1, target is low. And if the patient have renal problem or metabolic syndrome, more tight. What is the treatment for hypertension in diabetes? Which will be a selection? Of course, you will select something that is renal and cardioprotective, because diabetes can cause renal risk and heart risk. So we'll give ACE inhibitors. The first line for hypertension in diabetes, even if the patient is, Africo-Caribbean or elderly or whatever. The presence of diabetes is superior than the other issues, regardless of the age. Okay. Renoprotective, reduce the diabetic nephropathy, reduce albuminuria. طيب إذا كان black African with diabetes, common scenario. Patient hypertension, he is African and have diabetes.
Arab.
You will give, yes. If a black African without diabetes, you will give calcium channel blockers, right?
Yes.
But if a black African and have diabetes, so white with diabetes will give ACE inhibitors. Black African with diabetes will give Arabs. If type diabetes with albuminuria and without hypertension, ACE inhibitor. If with hypertension, ACE inhibitors. What about beta blocker in diabetes? You should avoid. ليش؟ لأنه البيتا بلوكرز بتلعب في السمباثيك والباراسمباثيك، والسمباثيك and the parasympathetic are usually the system which will respond to hypoglycemia. It will tell you this is the alarm، ده الرادارات بتاعت الهايبوغلايسيميا. إذا كان ادينا البيشن بيتا بلوكر ضربنا الرادارات بتاعت الهايبوغلايسيميا، حتجيه هايبوغلايسيميا تضربه من غير ما يحس بها. طيب في الحرب لما شنو تكون في قاعدة من غير رادارات بتاعت دفاع جوي، إذا ضربنا السمباثيك والباراسمباثيك ببيتا بلوكر، خلاص كده شلنا الإنذارات وشلنا الرادارات. Okay, it will mask hypoglycemia. That's why it should be avoided in a patient with diabetes. The best is ACE inhibitors in white, Arabs in African. The best hypertensive in diabetes. Which is the worst? The worst is a beta blocker. Hypertension in chronic kidney disease? Same. ACE inhibitors. Any question? I will leave the remaining for you in the website. I will update this note. And there is a lot of questions in the section of hypertension. You can go now and test yourself. ولا نحل لنا سؤالين ثلاثة؟ تحلوا براكم ولا نحل معاكم سؤالين ثلاثة يا جماعة؟ Who will answer this question? 45. White woman. Blood pressure 160 over 100 at the clinic. We send her home, ambulatory device. Then the average from 8 o'clock to 10 o'clock, we check 14 readings minimum. The average of these readings is 155 over 95. No diabetes, no CKD, no target organ damage, no established cardiovascular risk. What is the treatment? What is your decision?
ACE inhibitors or Arab?
Yes, agree all? Agree, Dr. Aisha? Agree?
Yes. Yes. أيوة.
Okay. Why? Because, below 55. Why? Already diagnosed hypertension. This is stage 2. But she is below 55 and white. Then, if it is above 55, calcium channel blocker. If it is black, calcium channel blocker. All right, 66. What is the best next step? ACE inhibitors or Arab, add, increase amlodipine, add, refer. 60. Amlodipine 10 for hypertension. خلاص maximum dose. يعني حتى ما في لها فرصة نضيف يعني. مع انه احنا ما بنزيد الجرعة لكن هو already جاي مكمل الجرعة. Clinic blood pressure high. He is adherent and has no ankle edema. Urea electrolytes are normal. And he's taking amlodipine. And the blood pressure is 156 over 94. Is it a target or not?
Above the target.
Above the target. That's what? That means not controlled.
Yes, you need to add it.
Okay, so we check him after 1 month after starting this medication and he's not controlled. He's not happy. So he is taking already amlodipine, then we need to add,
AC or R.
to add ACE or R.
Already on C.
ممكن زوم اوت شويه، ما قادرين نقرا تفصل. بس كبر الشاشه شويه.
طيب. All right. I'm 45. What is the most appropriate next step? Add, refer, stop. 45. Persistent hypertension despite ramipril, amlodipine, and dopamine. Uncontrolled. EGFR is acceptable. Potassium 4.3.
Marwan.
Added low dose of spironolactone.
Yes, because also we can add. طبعا in hypertension we can add the fourth medicine. In angina, we will give the first, we will give the second. The third, we will not give it unless there is appointment with the cardio. So the third medication in angina to be given when the patient is having plan and appointment with the cardio while waiting for the appointment. In hypertension, no, we can treat and treat and treat.
ده ما يعتبر resistant hypertension.
Not yet. هو
Three
ممكن
medications.
ممكن
She's on 3 medications.
3 medication in the resistance.
Important 3 medications.
Yes. So, what do you think?
Referral can be option also.
Huh?
Referral for investigation for secondary hypertension can be also option.
Okay.
If you consider that this is resistant hypertension.
Okay, this patient, you mean refer immediately without changing the medication?
I don't know immediately, maybe a little confusing immediately.
Yeah, that is why we excluded here. That's the squeezing point here. Okay. Expert advice may be considered because it is resistant, but spironolactone is appropriate because referred immediately without changing the medication. That means you will leave the patient with high blood pressure while waiting for the appointment. So you cannot. This is a style of the exam question. Yeah, and you will develop headache in selecting between two. If you say, oh, this is a resistant hypertension. So resistant hypertension is indication for referral. If he said refer, then we can refer the patient, but refer immediately without changing, yeah, it's not a correct, not a good choice.
This question, yeah, boss, exactly like exam.
Yes.
Mm.
They are testing now the clinical judgment rather than the information. لأنه everybody is خلاص memorizing the blood pressure and everybody now they are how you are using the information. Now the information under your touch. You can just go to any website, up to date, Medscape, GB Note, the website, AI, anywhere. You can get the information easily. But they will test you how you will use the information at the level of judgment. How to apply the information. Okay, here, for example, sure when to refer. Okay. I will share with you the note again. Okay, let's go back to the note. So this is when to refer. Severe, accelerated, malignant, or suspect is secondary. Correct? Right. Steps of management. First, second, third. This patient needs 4 steps. Yeah, still GB can do it. If uncontrolled, consider low dose spironolactone if the potassium is below 4.5. Is tomorrow in the exam give you potassium above 4.5, then alpha or beta blocker. Betaine mandatory to refer the resistant hypertension if it's still uncontrolled. And referral after step 4, doctor. Okay. If it's step 4, if it's still, after adding the force medication, if it's still resistant, then we can refer. Lano, it is not a logic to refer a patient and still you have something to do. Yani the specialist, he will give him spironolactone or alpha blocker or beta blocker, and you can do it. Why abuse the consultant? There will not be easy appointment. It's not like here in the Gulf. Okay, let's go back. .45 episode of headache palpitation is waiting. This is
Pheochromocytoma.
how to investigate? Appropriate investigation.
Epinephrines.
Most appropriate. The most appropriate is not an initial. We need the best.
Plasma-free metanephrines.
So plasma-free metanephrines or 24-hour urinary metanephrines. So if the others, plasma aldosterone renal, this is for Cohn syndrome. Ambulatory, this is not for measurement. Renal artery for renal artery stenosis, thyroid for. So this is a correct. Right. What is the most appropriate interpretation? 45, 44, type 1, blood pressure 138/86. What do you think?
Hypertensive.
Hypertensive.
Yes, because
Hypertension مع diabetes.
because diabetes type 1. Okay. And treatment should be considered. 32. Blood pressure 160 over 100. So several months after starting combine. What to do?
stop ال COCB.
Agree يا جماعة؟
No.
agree.
ده
Blood
أيانا
pressure.
جات
It's reading.
جات ب hypertension 160 over 100 يعني hypertension وينج 32 دي معناها شنو يعني secondary صح؟ secondary to combine.
Stop it, yeah.
السؤال كده صح يا دكتورة؟ كده استوى ولا لا؟
stop.
Yes, treatment of secondary is treatment of the underlying cause. Okay. Patient is young, below 40, having stage 2 hypertension. That is secondary by definition. Below 40, blood pressure is stage 2. That is secondary hypertension. What she's taking? She is taking combined oral. Yes, combined oral can increase the blood pressure. That is why hypertension is euchemic for combined. Am I right?
Yes, you can make 3.
ممكن يكون contra indicated في البيشنتس اللي عندهم severe hypertension combine oral حد. Okay. Okay يا جماعة, are you agree إنه combine oral ممكن تعمل hypertension؟
Yes.
Okay, bye. الاستروجين يا جماعة بيزيد الاستروجين will increase الangiotensin from the liver وبيعمل stimulation لتحويل angiotensin 1 لangiotensin 2. الاستروجين بيشتغل same like الالدوستيرون. It is stimulate angiotensin 1 to angiotensin 2. بالتالي will lead to vasoconstriction. اوكي, بالاضافه لانه بيزيد الالدوستيرون نفسه, فبيزيد الانجيوتنسين وبيزيد الالدوستيرون. ده استروجين. لكن البروجسترون اونلي ما بيعمل. اوكي, عشان كده الكومباين اورال بتكون contraindicated if the blood pressure is above 160 over 100.
دي بتاخد ACE لو هتبدأ.
كيف؟
If she when
We
to
need to
start على طول stop and start.
since in a young وكده we will investigate. Okay, we will investigate for other causes of a secondary hypertension. If nothing else, we stop a combined oral. If the blood pressure return to normal, you don't need to start anything. But if it is persist, that is something else. لكن البيشنت دي هسه دي okay, we stop a combined oral. You may not know to get their medication. Blood pressure will go down alone. Okay. So you can please go and do the question. I will update the note now. Also, the